Our next guest is Dr. Benjamin Walter. He is the section head of movement disorders and the director of the deep brain stimulation program at the Cleveland Clinic. He received his medical degree from MCP Hahnemann University School of Medicine in Philadelphia and completed his residency and fellowship programs at Emory University School of Medicine. He specializes in intraoperative physiological mapping for deep brain stimulation and pre and post-operative care of individuals undergoing DBS, as well as individuals with Parkinson's disease who do not have DBS. As you will soon learn, there are many exciting changes in the world of DBS, and he is the perfect person to introduce you to these. Please welcome Dr. Benjamin Walter.
Hello, I'm Dr. Benjamin Walter. I'm the section head for movement disorders at the Cleveland Clinic and medical director of the Deep Brain Stimulation Program. I'm going to be talking to you today about some of the exciting changes in the field of deep brain stimulation and other advanced therapies, including focused ultrasound and continuous levodopa infusions. First, I would like to talk a little bit about how Parkinson's affects the brain so I can further explain how these therapies work and what's new about them. First, as you may know, Parkinson's is caused by this pathology called Lewy bodies. Lewy bodies are neurons or brain cells that accumulate a protein called alpha-synuclein, shown here. And as it accumulates, it eventually causes the destruction of these cells and loss of dopamine, a neurotransmitter or a chemical that's important in the brain. If we look at where this is happening, deep in the brainstem is this area called the midbrain. The midbrain lies just above the spinal cord at the base of the brain and has this area called substantia nigra, which is a dark area that's pigmented from these cells that make dopamine. These are the cells that are lost in Parkinson's disease. These cells supply the dopamine to an area called the basal ganglia, which includes the striatum, where these cells have their terminal endpoints. And as these cells degenerate, there's pallor or loss of color to this part of the brain as seen in pathology, but the basal ganglia begins to function abnormally. What's important about this, however, is that with the return of dopamine or other changes, the brain does have the retained ability to function more normally again. Early in Parkinson's disease, one of the main treatments is Sinemet or carbidopa-levodopa. Levodopa is the active ingredient and is converted into dopamine in the brain. Shown on this slide here is a time scale from the time that the patient takes the medications here to 2, 4, and 6 hours later. And as you can see in early Parkinson's disease, the clinical effect that we typically see is you take the medication and it reaches some sort of threshold and it starts to work fairly quickly. And it's fairly smooth without side effects or dyskinesias or other problems, where over this whole time period, typically until the next dose is taken, the medication is working normally. However, this is not what the medication does in the bloodstream. It only actually lasts in the bloodstream for about 90 minutes. And shown here is, with this red line, is really what the medication is doing in the bloodstream. The reason that the medication lasts so long in early disease is the brain actually has the ability to recycle this. So levodopa is turned into dopamine, the dopamine is broken back into levodopa, taken back into those neurons in the brain, and they make more dopamine from it over and over again for a while. So it's actually fairly efficient and it's recycled. These same cells, the ones that I showed you before, though, are the ones that are lost in Parkinson's disease. So while you have a good response to the medication, typically throughout the course of the disease, this ability to recycle the medication and having it lasting for many hours at a time smoothly is lost. So in moderate Parkinson's disease, we see something more like this, where it's lasting somewhere between 2 and 4 hours. And in advanced Parkinson's disease, much less, more closely resembling the 90-minute timescale that we see for how the medication works in the bloodstream. And so another way that we have to treat this is with deep brain stimulation, and this is without medication. What we do here is we put a pacemaker wire, very much like a heart pacemaker, but the wire goes into a structure within the basic ganglia, and shown here is the subthalamic nucleus. We also can place these in an area called the globus pallidus, which is over here. But both of these nodes in the circuit have similar responses and can improve Parkinson's symptoms 24 hours a day, 7 days a week, because the stimulator is on all the time. And it allows the brain to function normally by restoring basal ganglia function. And this therapy has the ability, as seen in the clinical trials, to give half of the day back really to patients who have more advanced disease. So shown here are the clinical results from the original study. And you can see before surgery, patients have about half of their day where they're off. They have some time where they're on, but with troublesome dyskinesia, about a quarter of the day. And only about 27, about a quarter of the day do they have on time without troublesome dyskinesia. So 3/4 of their day is taken up by activities that where the disease is not under really good control. And shown here, both for subthalamic nucleus or STN and globus pallidus, the two different targets we use for this therapy, are the results, which are very similar. As you can see at 6 months, you now have all of that time, 3/4 of the day, where the patient has good benefit without troublesome dyskinesia and much less dyskinetic time and much less off time. So who's a candidate for DBS? First of all, you have to have typical or idiopathic Parkinson's disease. And with this, typically you have a good response to medication, particularly Sinemet or levodopa. There are some exceptions. Some people have tremor that can be very stubborn, but the other symptoms should respond well to medication. You should no longer be satisfied with the response you're getting to medication, thus making a surgical therapy more advantageous for you, and particularly the tremor, the stiffness, the slowness, and dexterity or dyskinesia might be some of the troubling symptoms that you have. These are things that deep brain stimulation can work very well on. And we also like to make sure that you're not troubled by uncontrolled depression, anxiety, or memory loss. These kinds of problems, particularly the mood disorder, should be optimized before an elective surgical procedure. So how do we approach people with Parkinson's disease who are looking for deep brain stimulation? First, we want to think about the diagnosis first. Does the patient have the right diagnosis for treatment? And that's the typical form of Parkinson's disease that responds to the medications. The next important point, which is one of the most important points, is the goals of therapy. What is the patient expecting to get from surgery? Is it something that the surgery will help? A lot of people have different ideas and perceptions of what these therapies may bring. And this is really true for all treatments, and particularly more true for these advanced therapies where there's a process to go through and some risk involved in some of these procedures. Then our next question is, have medications been tried adequately? It's not worthwhile to proceed with a surgical therapy if there are some good medications that haven't been tried that may have good benefits and resolve some of the major issues that patient has had. And fourth, we like to look at different predictors for good and bad outcome and how they weigh in an individual patient. Everybody is a little bit different, and some people are better suited for a procedure like this than others. When are medications not enough? Despite adjustments in medications, patient still has early wearing off before the next dose, frequent cycling between on and off episodes, sometimes unpredictable cycling. Tremor, as I mentioned, even if it's not responding to medication, responds very well to deep brain stimulation. So that doesn't have to be responsive to the medication as the other symptoms should. And troubling dyskinesias. Dyskinesias are those involuntary movements that patients have in some cases when the medication is working or when it's starting to wear off. And it's different from a tremor in that it's more of a regular, what we call creiform movement, which is kind of a wiggly movement that the patients may have. What are realistic expectations from surgery? Improvement of the tremor, improvement in dyskinesia, less fluctuations, so less up and down periods, longer lasting benefit through the day, improved slowness, improved dystonia or cramps when that occurs. You can expect some reduction in medication, but that really shouldn't be the goal for having a surgical procedure. And Freezing is a little bit tricky. So when people freeze when they walk, sometimes that responds to medication and sometimes it doesn't. And it often becomes more resistant to all therapies as the disease progresses. If a patient just has a little bit of isolated freezing when their medications wear off, thus the medication is helping it to some degree, that's predictive that they probably will respond with their freezing to deep brain stimulation. But again, over time, the freezing might be a little more resilient. So that's a trickier symptom to treat in general. What are not realistic expectations? Improving on freezing or freezing that occurs when the medications are still working at their best. Improving balance, memory, autonomic functions such as swallowing problems or bladder function dysfunction are things that some people may experience for different reasons or in advanced stages of Parkinson's disease. And these are things that don't typically respond to deep brain stimulation at all. So the most important thing, again, are what are your goals? What are you looking for to get from this therapy? And do your goals align with what we can deliver? We want to make sure that we're all on the same page before proceeding with something like a surgical procedure. And the most important thing, of course, is that the patient gets from the surgery what they are anticipating from it. So it's very important that everybody's well educated and understands and agrees on what our goals are. What's the process like? Typically, you'll see a movement disorder specialist. You'll have medication testing, what we call levodopa response testing, where we have you stop your levodopa and other dopamine medications the night before evaluation. We examine you and grade or score the severity of your symptoms, have you take some medication, sometimes a little bit more than usual, and then wait a half an hour to an hour for the medications to kick in or work. And then we'll evaluate you again the same way, so we can get a sense for what is responsive to medication and what isn't, how bad your symptoms are at the worst point when the medications are not working as well, and how well they're working. We'll talk more about your goals and make sure that we're all on the same page and you have goals that we think the therapy can adequately deliver for you. And you'll have neuropsychological testing or memory testing evaluated by the neurosurgical team for any medical risk of a surgical procedure. A brain MRI is typically done as long as it can be, so we can see the structure of the brain, which is also used for targeting. And then our whole team gets together, discusses the case, and we'll give a recommendation on the approach, what kind of equipment should be used, whether it's a good idea or not, and we get back to what the recommendation of the team is. After you've been approved for DBS, you'll have pre-anesthesia testing, which is done 30 days prior to the surgical procedure, just to make sure that you're still healthy, there's no new medical problems. It's really a screening procedure to make sure that you're ready and fit for surgery. And then the surgery is done in different stages, first implanting the wires, and then the pacemaker or battery that goes in the chest, and everything is hidden underneath the skin. And then about a month after the surgical procedure, you come in for programming. And the programming is typically done on several visits. We slowly adjust medications and stimulation so we can get a new balance. And typically, you're going to be on much less or lower doses of medication, and the stimulation starts taking over some of the work. Typically, though, patients still will remain on some medications. So there are different targets for deep brain stimulation, and this isn't something that you really have to pay too much attention to, but it's worth knowing about. The subthalamic nucleus is one target, and then a very commonly targeted area where we can put the pacemaker wire. And then GPI, or the globus pallidus internal segment, is another one. They're both nodes in this circuit that's involved in Parkinson's disease. And for some people with Parkinson's, we will also target the thalamus. The thalamus has areas that can control tremor. So if we target the thalamus with deep brain stimulation, I'll talk a little bit about focus ultrasound as well. The thalamus will control tremor, but it's not going to control the other symptoms of Parkinson's disease. And that goes for deep brain stimulation or for focus ultrasound. Between the two major targets for the Parkinsonian symptoms, the globus pallidus internal segment and the subthalamic nucleus, there has been some hot debate in the clinical literature and amongst experts in Parkinson's disease, but this has mostly been resolved that both targets are actually quite good, and some might be better for one patient than another. So we help make a judgment how we can customize or optimize, personalize the surgery for individual patients, including the choice of target. Like I said at the introduction, it's really an exciting time. There's been a lot of changes in this field. At one point in time, we had just one company that made deep brain stimulation devices. Now we have three. They all have different and very exciting options and different features to choose from, and it's constantly changing. Every couple months, we're hearing about new things and new changes, and oftentimes there's additional functions that are enabled in these devices as well. So it's really exciting time and a great time to have deep brain stimulation. Let me talk about a few of these major changes. First of all, it's often said, and we will remind folks that you have to be careful with MRIs with deep brain stimulation. But all three companies now have, under certain circumstances, full MRI capability. And there are differences, and not everybody has the same capability depending on how their device is implanted and working for them. But Medtronic's devices are their newest device, I should say, is compatible with a 3 Tesla MRI. All three can be done at 1.5 Tesla MRI. And this allows you to get further imaging for brain issues or other issues with your body if you should need an MRI. Of course, when it can't be done or if it's limited, there are other imaging techniques that are available. But for the most part, as long as this is done at a major medical center, your device is checked out and you meet all the requirements, you can typically have an MRI. We typically will tell people to not let just anybody do an MRI on them, make sure they're checking with the implanting team to make sure that it's compatible. Directional leads is very new, and this is a great addition. And I'll show you a video and a little bit of what this means just to give you an idea. But essentially, it allows us to have much more control in moving exactly where in the brain we're stimulating electronically up and down the wire, left and right, forward and backwards. And we can make these small adjustments just by electronically programming the device and controlling where along the wire it's stimulating. So there's no surgery needed to make these adjustments. It's really all done in the office with a handheld remote, which looks a lot like, or may actually be, an iPhone or a similar device. And the other really exciting change just in the last year or so is brain sensing. And this is with the Medtronic product. And I'll show you a video in a little bit what this means, but it allows us to measure how you're doing in a real-time basis or while you're at home and be able to adjust the DBS based on this. It's really exciting. So the directional leads, like I said, are available for all three companies now. And they're essentially segmented leads. So what this means is typically there used to be 4 cylinders along the wire, and these are each what the different wires look like. And these metal areas as shown here are these cylindrical contacts. But what they've done is all three companies have taken the middle 2, as shown here, and split it into thirds. So if you look at from the top, you can see the bottom is a solid cylinder, and the 2 in the middle are split in thirds. And then this top one up here is also a solid cylinder. What this allows us to do is to turn any one of these 8 elements now on individually or in concert, so we can direct the stimulation field sideways from the wire. And I'll show you in this next video what this looks like. This is actually the Boston Scientific device that's illustrated here. And you can see what's happening. This red area is just illustrating what we call the volume that it would affect, or the volume of tissue activation, just moving it up and down the wire first and turning it up and down. But now what you'll see is now the directionality is being used where some of those segments are being turned on selectively, and now you can push it sideways and around. If we have a target that we're trying to stimulate, this green area here represents the subthalamic nucleus and is about the size of the target. You can see how small that is. We want to fit that volume of activation inside that, but not spread outside where we might get side effects. And so with this technology now, we can move it up and down and direct it in the direction of that target and increase it just to the point where we're getting the right amount of stimulation and not spreading stimulation into areas that we don't want to stimulate. The other great technology that's fairly new, although there's been some for a while, but it keeps changing again, is the rechargeable batteries. The rechargeable batteries are now good for at least 15 years. And they're made by Boston Scientific and Medtronic currently. And the primary cells or the other battery type last for about 3 to 5 years. The nice thing about the primary cells is they don't need to be charged. The rechargeable batteries do, so you charge them up once a week for about an hour or maybe 15 minutes at night. You wear like a vest that's already been charged up itself, so you don't have to be tethered to the wall, to get the electrical power. The vest is charged up. Works a lot like an electric toothbrush, essentially. But what this allows for is 15 years without having a battery replacement, which is really phenomenal. So it's not for everybody. It's particularly a great option for people who might be at high settings, who are going to be on the lower end of battery life. And we know this, typically after the first couple of years that you have your DBS, what kind of settings are you requiring? And are they settings that will eventually make rechargeable more useful? And it's also, a good option for people that are likely to keep their batteries charged. Of course, if you're not going to use the technology properly, it may not be the best option. And then the other ones would be good for somebody who doesn't want to have to deal with that. So we have options that are good for all people. It really just depends on what your needs are. This is new, and this is really exciting. That really was facilitated technology advancement really because of the COVID pandemic, but things that were in the works anyhow, and that's remote programming. So, many of you are familiar with remote or virtual visits. Now with the Abbott device, we have the ability to do a remote visit, and I'll show you here what one looks like. This patient of mine was very nice to volunteer to allow you to see what his programming session was like. And so we demonstrated here, and you can see on the left here and on the right-hand side is a view from my program. Now he can look at me and I can look at him. And his stimulator is off right now for the right side of his body. And I just turned it on. Little tingling. You can see that it's at 1 milliamp. And we're going to go up a little bit higher. So that's a low setting. And he still has some tremor in his right arm. And this is all being done. He's in his home. I'm in the office. And it's a secure interchange. He has to give me permission to do that. Slowly get better. He's at 1.3 milliamps now. You can see that there. And I can see the contacts that we have are on the left side. And I'm slowly turning it up on my device. Okay, now you're at 1.5. And I can flip through these different screens to adjust different parameters. But you could start to see, particularly in this case, as he gets up to closer to 2 milliamps, which is happening now, that tremor starts to go. How about now? How does it feel? Pretty good. And now you can see that his tremor's gone. I'm going to go up a little bit more. So this is great for maybe not the first programming session. We typically want to do those in person. Now with your right hand, can you go like— But over time, we might want to troubleshoot while somebody's at home, or just have the convenience of being able to have the programming visit at home, particularly if you live far away from the Cleveland Clinic or a major medical center. So this is a huge advancement, really, really a wonderful change for this field. If for some reason our connection gets lost, we have a default setting that he's set to, and he'll automatically go back to that safe setting so that we're not left somewhere in something intermediate where we didn't decide that we wanted to stay there. So there's a lot of safety features that are built into this.
When a person with akinetic, rigid Parkinson's disease exhibits near normal mobility, brain signals may show moderate synchrony with minimal frequency peaks. When a person with Parkinson's disease experiences movement challenges, brain signals may be excessively synchronous with a peak at the beta frequency band. The Percept PC implantable system for deep brain stimulation from Medtronic is the only system that can chronically detect and measure signals from the brain. BrainSense lets clinicians capture these signals from the brain both during and between visits, and this personalized information, along with other clinical information, may be used to inform clinical decisions.
So this is what this device looks like, and the Percept is their latest model from Medtronic. It's a little rounder, a little smaller. This is the pacemaker device that goes in the chest. But what's really exciting about this is the inner workings of this and how it works. And you saw in the video, what we're able to do is get these signals out of the brain, and it's shown here, but it has a lot of different uses and features. These signals, some of them increase when Parkinson's symptoms are worse. There's other signals, something called gamma that goes up when you have dyskinesia. And the patients have the ability on their own patient programmer, which is this device here. It's a Samsung handheld. They can mark events throughout the day of how they're feeling. And so if they're having some problem that we're trying to figure out what is going on, what is that? Is it a high medication state, a low medication state? Is it too much stimulation or too little stimulation? They can mark what's going on, and we'll have a recording of that time, what the brain signals look like at the time that they experience that. So we can tell whether you're having more Parkinson's symptoms or you're getting too much medication or stimulation. And we can graph these over time so we can get a sense for what's your level of control. This tells us a lot about the medications, how to adjust your medications, and how to adjust your deep brain stimulation. And there's another really exciting feature about this. This is really just the beginning. Because there's currently clinical trials looking at further advancing this therapy with this same platform called closed loop stimulation, where we can actually set parameters for where we want you on the low end, where we want you on the high end with your stimulation settings, and actually use those signals to adjust between those two ends of the spectrum. And this allows for the deep brain stimulation to smooth out the edges in your day and give you even better control, and actually probably lower energy utilization as well. So this is in the future. This particular part of the technology is in clinical trials. We're actually a site for this right now, so it's very exciting, but it's not yet approved for regular use. The rest of the device is, however, and so we are able to use those signals and those information to manage your Parkinson's disease, which is really still phenomenal. Now I'm going to show you a video about focused ultrasound, and this is
Bill Purcell can finally enjoy a cup of coffee. For the past 5 years, he suffered from essential tremor in his left hand, and being left-handed, it was severely disabling.
At first, the medication seemed to be working, but then it just got worse and worse. So I couldn't really write anymore. Couldn't drink a cup. I have to use two hands.
Bill was not a candidate for deep brain stimulation surgery because of his history of mini strokes, but he did qualify for a new incision-free focused ultrasound treatment.
The focused ultrasound allows the physicians to target a very specific area of the brain, and as you slowly increase the energy over time, you can see the warming or the heating of the tissue within the brain itself using the MRI.
Bill was awake during the procedure and gave doctors feedback while they heated specific areas of his brain.
we can start to see that their tremor is responding before actually increasing the energy enough to cause the permanent lesion.
The lesion interrupts nerve signals, causing the tremor, and it stops immediately.
We were able to give him a cup of coffee, which for the first time in several years he was able to drink without spilling any.
Savoring a cup of coffee is one thing, but the procedure also allows him to hold something much more precious, his newborn granddaughter.
So that was focused ultrasound, and it's really a special therapy. Again, this is approved for both essential tremor and for Parkinson's. It's something that is used on one side of the brain, so we can't control tremor on both sides. So it's really to control one side. It can't be done on both. And that is different from deep brain stimulation that can be done on both sides. But there's no implanted hardware and there's no surgery. And so some of the risks are different. Some of them are better in that sense. So it's not for everybody, but it's a great option for some people with Parkinson's who have tremor that is bothering them, that do not want to go through deep brain stimulation, or have other medical issues where they can't undergo anesthesia. They can't have an implanted device because of infection risks and things like that. So there's a number of different reasons why people might select this therapy, but it really works in one of the same targets that we use for deep brain stimulation for tremor. Again, this doesn't help the slowness and the stiffness and the dystonia. It's really for the tremor. Another therapy that we have available is Duopa, or levodopa intestinal gel. This was approved in January 2015. And if you can imagine, and one of our biggest goals with medications, particularly the main one that we use is levodopa, is getting this medication stable through the day so that you have kind of smooth control all day long. So what if there was a way that we could give that medication continuously so that those levels stay very stable? Well, this is the way to do that. And it's a pump. It goes through a tube which goes into the stomach. So it's very much like a feeding tube. This is a PEG-J tube, which is a little different from a PEG tube, but it looks the same from the outside. This goes into the stomach, and then there's a tube inside there that goes into the jejunum, which is the first part of the small intestine, which is illustrated here. But what the medication levels look like is shown over here, where it's turned on in the morning, and basically the patient has very continuous levels of medication for 18 hours a day when it's on. It's typically turned off at night to give the GI tract some rest. So this is another great therapy that's available for people with Parkinson's disease and motor fluctuations. Looking to the future, we have a lot of clinical trials. Research is always the window to our future and where future therapies are available, at least to try right now. And the other great aspect of research studies, it's a way to pay it forward for people with Parkinson's to help develop therapies for themselves and for other people to use in the future if they get approved and if they show that they're very effective. Some of the kinds of treatments that are coming through research, therapies that are looking at modulating or slowing the progression of Parkinson's disease, smoothing out motor fluctuations, treating other symptoms related to Parkinson's disease, for example, constipation or blood pressure control. There's trials developing wearable technology so we can monitor symptoms better and further develop therapies faster, and also be able to monitor and optimize your treatment better while you're at home. Exercise and cycling studies for Parkinson's. We have a couple of these going on right now, both a cycling study and a treadmill exercise study. And then I also mentioned that we have the closed loop responsive stimulation study as well. So we have over 40 active trials at a given time. There's a lot of opportunities here. So please ask your doctor about some of the different research options that are available. And I thank you so much for your time and attention, and I look forward to your questions in the chat.